Welcome back to NephroTube online nephrology lectures. In this lecture, we will cover one of the most important electrolyte disturbance that we see in our practice, which is hyponatremia. And we will discuss it in a practical way. First of all NephroTube webinars are available on our YouTube channel NephroTube, and also the PowerPoint of all NephroTube lectures are available at nephrotube.com, and you can join our Facebook group and follow and like our Facebook page, Twitter account to follow up updates and announcements of next webinars. First of all, the normal serum sodium is about 135 to 145 milliequivalent per liter, and hyponatremia is diagnosed once serum sodium is below than 135 milliequivalent per liter. And it is well known that hyponatremia is the most common disorder of body fluid and electrolyte balance in our clinical practice. Also, as an introduction, we know that total body water is divided into main two compartments: the intracellular fluid, which is inside the cells, and extracellular fluid, which is in the interstitium and in the plasma. The main intracellular ion is the potassium, while the main extracellular ion is the sodium. So sodium mainly is a extracellular ion. Hyponatremia is a primary disorder of water balance. In hyponatremia, we will always find more water than sodium in the extracellular space. So after this introduction, what will be my talk outline? I will talk about the presentation of hyponatremia, diagnosis, and management different steps. Starting by presentation. The clinical presentation of hyponatremia is mainly neurological and related to central nervous effects. Symptoms are divided according to the severity into moderately severe and severe option or severe symptoms. The moderate severe are in the form of nausea without vomiting, confusion, headache. The severe presentation in the form of vomiting, cardiorespiratory distress, somnolence, seizures, and coma. The presentation to be moderately severe or severe depends on the magnitude and rate of hyponatremia. As we will discuss later, the magnitude, how much the sodium decreased, and the rate, how rapid the sodium decreased, will affect the severity of the symptoms. The more the magnitude and the higher the rate of hyponatremia, the more severe the symptoms. As you saw in the past slide, that symptoms are mainly central. So what is the pathogenesis of central effect of hyponatremia? As we all know that intracellular osmolarity, which is or which depends on the ratio between water and osmoles, especially sodium, is the same in the intracellular compartment and extracellular compartment. So osmolality is equal in both compartments in our body. In case of hyponatremia, as we said that sodium is mainly extracellular ion, sodium will decrease in the extracellular compartment, which decrease the tonicity and osmolality of the extracellular compartment, then intracellular part. That will cause shift of water from the extracellular compartment to the intracellular compartment with swelling and edema of cells. One of these cells is the brain. So in cases of hyponatremia, we will find the brain swelling and edema. And as we all know that the compartment of the skull is not expansible, can't be expanded easily. So this will lead to increase in intracranial pressure, causing the well-known central manifestations of hyponatremia. So how brain adapt to hyponatremia? when there is brain swelling, what the brain will do, trying to decrease this edema and this pressure, especially in chronic cases. The brain adapts in different ways. The first way, in cases of brain edema and congestion, there will be increased CSF flow, which will remove increased water from the brain. The second and more important mechanism that brain used to adapt hyponatremia is removal of intracellular solutes. You will find that some solutes will move from intracellular of the brain, cells of the brain, to the extracellular space, and this will osmose water with this movement to make equilibrium between the intracellular space and extracellular space as possible. What are the osmoles that the brain will try to get rid of from the intracellular space to extracellular space? And this will lead to get rid of excess water from the brain cells to the extracellular space. First of all, brain will try to lose sodium, potassium, and chloride, but this is not the most important. The most important is that the brain, by using some carriers and channels, we lose organic osmolytes, and organic osmolytes will loss of organic osmolytes will osmose water with them from the intracellular space of the brain to the extracellular space. The most important point that this brain adaptation is slow, and in chronic cases it may take about 48 hours. And this is an important issue that we will depend on when we will try to correct hyponatremia, that we have to avoid rapid correction of hyponatremia. Because with rapid correction of hyponatremia, the brain will try to reuptake the organic osmolytes again into the cells. And the reuptake of these organic osmolytes will be also slow. So correction of hyponatremia must be slow to give time to the brain to adapt for the correction of hyponatremia. And as brain adaptation to hyponatremia is slow, so correction must be slow. And we'll talk about this in details later in this lecture in what is called osmotic demyelination syndrome. So that what was related to presentation. What about diagnosis and how to diagnose a case of hyponatremia? We'll go through 5 steps. Step 1, once the lab shows hyponatremia, you have to repeat serum sodium because the lab error is very common and blood drawing error is very common. So don't exhaust yourself going through the big approach that I will use now before being sure that the patient is truly hyponatremic. But if the patient is symptomatic and the hyponatremia is severe, you have to start a treatment. But if you have time to repeat serum sodium, so it's better to repeat it. What are the precautions of sample taking for the assessment of serum sodium? First of all, be sure that blood should be drawn through skin, not from an intravenous line that is attached to the patient. And also, the blood should be drawn from a vein that doesn't have intravenous fluids, especially glucose, dextrose, because this will dilute the sample. The second step, after you are sure that the patient is hyponatremic, you have to check the drugs that the patient take. Actually, a lot of drugs with different incidence affect the level of sodium and cause hyponatremia. And here comes the role of the clinical pharmacist to check the drug list of the patients. So what is the third step after repeating the sodium level and after revising the drugs of the patient? Before going to the third step, I have to talk about what is the relation between sodium and the plasma osmolarity. As we all know that sodium, blood urea, nitrogen, and glucose are used in the equation for the estimation of the plasma osmolarity. So it is logic that when sodium is low, in case of hyponatremia, the plasma osmolarity will be low. Normally, the plasma osmolarity ranges between 275 and 295. And one of the most important electrolytes affecting the plasma osmolarity is sodium. So logically, when sodium is low, in case of hyponatremia, the plasma osmolarity will be low. So in true hyponatremia, where sodium is really low, actually low, the plasma osmolarity will be low. And this is what's called true hyponatremia. True hyponatremia is hyponatremia with low osmolality because sodium level is truly low. But we have two types of hyponatremia. One is called pseudohyponatremia. The patient will have a normal osmolality, and translocational hyponatremia, there will be high osmolality. And both of those pseudo-hyponatremia and translocational hyponatremia are not true hyponatremia. Because one of them, as I will show you now, sodium is not low, it is a lab error. And the other, the sodium is low, but secondary to other factors not related to sodium disorder. Let's start. So the third step that is important, we have to exclude pseudo and translocational hyponatremia because treatment of hyponatremia is specific only for true hyponatremia with low osmolality. In pseudohyponatremia, this is a lab error. We will find other causes and we will not treat the hyponatremia itself. A translocational high osmolality hyponatremia, we will not treat hyponatremia itself, we will treat the cause. So we have to exclude the presence of pseudohyponatremia and translocational hyponatremia, and this is step 3. Before going how to differentiate between the 3 types of hyponatremia, let's talk about pseudohyponatremia. It is hyponatremia in patients with normal osmolality. And before going through pseudohyponatremia, I want to talk about slight introduction. As we all know that our blood is composed of plasma and cellular elements. Plasma contains water, lipids, proteins, and other inorganic substances, and cellular elements are RBCs, white blood cells, and platelets. My question is, in which compartment of these compartments we are measuring sodium concentration? Yes, the answer is in water. We are measuring sodium concentration in water. So what is the importance of this point? We have to put in mind while we are trying to diagnose hyponatremia that we are measuring sodium concentration, not sodium level. For example, to get what I mean, in this cup of water, we'll find that sodium concentration is 50%. And this cup of water, although the amount of sodium is less than the left cup of water, you will find also the sodium concentration is 50%. And this, what is important in our body, the concentration of sodium in the water. The normal sodium serum level is 135, 145 milliequivalent per liter, whatever the number of the liters of waters in our body. Why I am talking about this introduction? This to go back to pseudohyponatremia, normal osmolality. Pseudohyponatremia or normal osmolality occurs in patients with hyperlipidemia and hyperproteinemia, in patients with high lipid level and high protein level. How is that? This is a lab error. Normally, this is a sample from patient. As I said before, this is the cells, this is a plasma water that we have to measure sodium in it, and the protein and lipid volume that is related to the plasma volume. Sodium is here, and we measure sodium here. One of the methods that measure sodium concentration called the flame photometry. The flame photometry measure apparatus the flame photometry apparatus measures sodium in relation to all compartments, to all plasma volume, not only in relation to the plasma water. It measures the concentration of the sodium to the all plasma volume. That's why in cases of hyperproteinemia and hyperlipidemia, the volume of the lipid and protein increased and the volume of the plasma water decreased. Sodium is here in the plasma water. So when the flame photometry measure here the sodium level and measure it to all the plasma volume, this will show a lower sodium level, although its concentration is normal in relation to this volume of water. But the flame photometry measures the sodium in relation to all the volume. So the high protein lipid volume, which take space from the water, will cause a bias in the test and cause non-accurate or non-true decrease in the sodium level. Let's explain it in an easier way. Say this is a blood volume. In the sample, we have the cells at the bottom, proteins and lipids at the top, and this is the part which contains water plus sodium. In this compartment, sodium concentration is 50%. I'm using non-true values just for explain what I want to say. So here concentration of sodium is 50%, but to all the blood volume is 25%, and we can say it is to the plasma volume, it's about 30-35%. In case of hyperlipidemia and hyperproteinemia, let's check these concentrations. Sodium concentration to water is still 50%, so it is normal. But the flame photometry measure it to all the plasma volume. So the sodium concentration in relation to the plasma volume decreased because the water compartment decreased second through high protein and high lipids. And this gives false hyponatremia, and this is what is called, why it is called the pseudohyponatremia. So flame photometry measures the sodium in both the aqueous and non-aqueous phases of plasma. The new tests for the hyponatremia depends on what is called unspecific electrodes, and this avoid the fallacy of the flame photometry, but actually pseudohyponatremia still occurs despite the use of ion selective electrodes. So it is important to exclude the pseudohyponatremia, as we will say. There is an equation to get the corrected sodium in cases of increased triglyceride and protein, but actually it is not widely used. So this pseudohyponatremia. What about translocational hyponatremia? Translocational hyponatremia, it is hyponatremia with high osmolality. It occurs when there is high serum glucose or hypertonic infusion as mannitol, or when there is irrigation for the prostate or bladder with the urologist, whatever the type of hypertonic infusion. Glucose or any hypertonic infusion will increase the osmolality of the blood and will draw or osmose water from the cells into the blood volume. This will cause expansion of the water content or increase in the water content of the extracellular space in the plasma, and will cause dilution of sodium and hyponatremia. So here sodium is truly low. It is not a lab error, but the osmolality is high due to the glucose or the hypertonic infusion. We can use also here a corrected sodium equation. There are two equations to get the adjusted sodium, corrected sodium, to know in cases of hyperglycemia or hypertonic infusions, is the patient really hyponatremic or not? And the management sure here is to treat the cause, for example, treatment of hyperglycemia. So now we know that we have true hyponatremia, which is hyponatremia with low osmolality, and the one that we have treat the hyponatremia specifically. And we have two types of pseudo hyponatremia and translocational hyponatremia that we have to exclude and we have to treat the cause. How to differentiate between the three types of hyponatremia? Logic is by measuring plasma osmolarity. But if you are working in a place, and this is very common in many countries, the plasma osmolarity test is not present, you can depend on clinical context and some investigations. For example, in pseudohyponatremia, you have to exclude hyperlipidemia by doing serum cholesterol triglyceride level and excluding hyperproteinemia by doing total protein level. And to exclude translocational hyponatremia, you can check the patient blood glucose, and you will have the history of the patient if he had any hypertonic solution infusions. So to revise, in step 1, we repeated the serum sodium level. In step 2, we excluded the drugs. Step 3, we will exclude hyperglycemia and other causes of non-hypotonic hyponatremia. I mean here to exclude pseudohyponatremia with normal serum osmolality and translocational hyponatremia with high osmolality. So now, if the patient is hypotonic hyponatremia, which is a patient with hyponatremia and low osmolality, step 4, we have to ask ourselves, is there severe symptoms second to hyponatremia? If yes, you have to treat immediately before going through the diagnostic approach. If no severe symptoms, we will go to step 5 to diagnose the cause of hyponatremia. I will start by step 5 and I will leave step 4 for the second part of the lecture, how to treat severe symptoms. Let's go through step 5 to diagnose the cause of the hyponatremia. As we said at the start of the lecture, that hyponatremia is due to more water than sodium in the body. We have 3 types of true hyponatremia with low osmolality. First, hypovolemic patient who lost water and sodium, but the patient loses sodium more than water. That's why he is hyponatremic. The other is avolemic patient. The sodium level is normal, but the patient gain excess water, but the excess water gain is not enough to make a hypervolemia, so the patient is still avolemic clinically. And the third type of true hyponatremia with low osmolality is hypervolemic hyponatremia, where the patient gains both sodium and water, but the patient gains more water than sodium. So we have 3 types of hyponatremia: a patient who is hypovolemic, a patient who is avolemic, and a patient who is hypervolemic. So the logic to differentiate between the 3 types is to assess the volume status of the patient, check our patient if he's hypovolemic, avolemic, and or hypervolemic. But we all know that the assessment of volume status is clinically maybe not accurate, maybe misleading in some situations. So clinical assessment of volume status generally not very accurate, likely to lead to misclassification of hyponatremia, and for sure this will affect the treatment approach. Clinical assessment of volume status has low sensitivity and specificity, so all algorithms that start with a clinical assessment of volume status are not accurate. So what we have to do in our approach that I will mention, which is the easiest and the most practical approach, as I think till now, is the clinical practice guideline on diagnosis and treatment of hyponatremia that was published in Nephrology, Dialysis and Transplantation 2014. In the approach that I will show now to you, we will start with urine osmolality and sodium concentration, and both best determined in the same urine. So do both of them at the same time. And it's better to use the terms effective circulatory volume and extracellular fluid volume instead of hypo, or avolemic patient. We have to differentiate between the volume of water in the intravascular space, which is called effective circulatory volume, and the volume of water in the interstitium, I mean edema, which is called extracellular fluid volume. Because, for example, in heart failure patients, we say the patient is hypervolemic, but actually the hypervolemia is only in the interstitium, while the intravascular space may be in a hypovolemic state. So the approach that I will show you now will use the terms effective circulatory volume and which reflect effective circulatory volume, which reflect the blood volume, and the extracellular fluid volume, which reflect the amount of water in the interstitium and edema. Let's start. We said that we will bypass if there is severe symptoms. What we will do, I will tell you now. Step 5, no, there is no acute or severe symptoms. We'll measure urine osmolality. If urine osmolality is less than or equal to 100 milliosmol per kilogram, we will consider etiologies of high water intake or low salt intake, which will make the urine is diluted because of high water intake or low solute intake, as in primary polydipsia, low solute intake, or pure potomania. If the urine osmolality is more than 100 milliosmol per kilogram, we have to measure urine sodium concentration. The etiology will differ according to the urine sodium concentration. If the sodium concentration in urine is less than or equal to 30 millimole per liter or more than 30 millimole per liter, and some references used the cutoff of 20 millimole rather than 30. If the sodium concentration in urine is less than 30, that means that the kidney retains sodium and water, but it retains water more than sodium. That will make the patient hyponatremic. And as it retains water more than sodium, that's what makes the osmolarity of the urine is more than 100, because more water and sodium reabsorbed, but water is more. So the excreted in the urine is sodium in a small volume of urine. That's why the osmolarity will be high. But the urine sodium is low because some of the sodium is reabsorbed into the body. This occurs in patients of heart failure, liver cirrhosis, and nephrotic syndrome, and you will find all these patients, as I said, I will use these new expressions. You will find these patients with expanded extracellular fluid, I mean edematous patients. And also, you will find the same shape if the patient had diarrhea, vomiting, third spacing, or remote diuretics. Remote diuretics use means the use of diuretics since a long time ago, and the patient stopped it, but its effect is still present. In these patients, you will find them with a reduced extracellular fluid volume and dehydrated. If the urine sodium concentration is more than 30 millimole, ask yourself, is the patient using diuretics or has kidney disease? If yes, consider this the cause. If no, check the patient extracellular fluid volume. If it is reduced, this may occur also with vomiting, primary adrenal insufficiency, renal salt wasting, cerebral salt wasting, occult diuretics. Occult diuretics is using diuretics in a hidden way. If the extracellular fluid volume is normal, consider Sciada syndrome, secondary adrenal insufficiency, hypothyroidism, and also occult diuresis. Actually, adrenal insufficiency, whatever primary or secondary, causing hyponatremia, because adrenal insufficiency will be associated with hypoaldosteronism. And aldosterone is an important hormone for the reabsorption of sodium from the distal tubules. So in case of hypoaldosteronism, you will find hyponatremia. Regarding renal salt and cerebral salt wasting, I will talk about them now with Sciada syndrome. Regarding hypothyroidism, how hypothyroidism causes hyponatremia. Actually, hypothyroidism alone is not enough to cause hyponatremia. Recent evidence showed that hypothyroidism to cause hyponatremia, it must be associated with severe mixed edema and severe effect on heart with heart failure and decreased cardiac output. But generally or theoretically, it may cause hyponatremia. An important point is this approach, this diagnostic tree is a simplification and doesn't guarantee completeness in each individual. And as you see here, they suggest at the end of the protocol that you may suspect or other causes, whatever the shape of the urine osmolality or the urine sodium, because also the patient may have combined effects, combined etiologies. Now, as I think that we usually need this approach very rarely, because the cause is usually of hyponatremia is usually apparent. You will find the patient in heart failure and hyponatremic, liver cirrhosis, nephrotic syndrome, diarrhea, vomiting, third space loss. The patient is using diuretics, the patient is in kidney disease. So usually the cause of hyponatremia is clear. But if the cause is not clear, or if hyponatremia is resistant to treatment, you may need to consider this approach to diagnose one of these causes. And I think this approach is important or is designed mainly to diagnose this part of the diagnostic tree. Okay. Now we will differentiate between adrenal insufficiency, hypothyroidism, and SIDA syndrome, because SIDA syndrome is a diagnosis of exclusion. We will diagnose SIDA syndrome in absence of adrenal, thyroid, pituitary, or renal insufficiency. So assessment of the thyroid function and adrenal function is important steps of the diagnostic approach of hyponatremia. And also you will find in cases of SIDA syndrome, low serum uric acid and high fractional uric acid excretion. So SIDA syndrome is a diagnosis of exclusion after exclusion of all other causes of hyponatremia. Many causes of inappropriate antidiuresis, SIDA syndrome, I will not go in depth through them, but it may be caused by malignant disease, pulmonary disease, and one of the most common is disorders of the central nervous system, other causes, hereditary, whatever, and drugs. Okay, so finally, SIDA syndrome is diagnosed by exclusion. So if I exclude or other cause of hyponatremia, SIDA syndrome is the diagnosis, the answer may be no, because we have another important cause of hyponatremia with high urine sodium, but with low extracellular fluid volume, which are renal salt wasting and cerebral salt wasting. And they also are very rare causes of hyponatremia. And the main problem that their effect, as I will discuss now, is approximately the same as SIADA. So if I excluded all causes of hyponatremia, the diagnosis may be SIADA syndrome or renal salt wasting, cerebral salt wasting that I will mention now. So first of all, is there a difference between renal salt wasting and cerebral salt wasting, or what is the difference between them? Cerebral salt wasting occurs when there is a brain injury. With brain injury, the brain releases more of brain natriuretic peptide. Brain natriuretic peptide will act on the kidney, cause natriuresis and loss of sodium in urine. Loss of sodium in urine will cause loss of water also and cause hypovolemia. And the hypovolemia will induce ADH release with retention of water and hyponatremia. Renal salt wasting is salt loss through kidney, and also they called this disease salt-losing nephropathies. This is due to tubulopathy due to any cause after chemotherapy, in analgesic nephropathy, medullary cystic disease, or any effect or any disease that will affect the tubular handling of the sodium. But recently, there is a question about if there is a difference between these two diseases, cerebral salt wasting and renal salt wasting, or they may be considered as one entity. And this article, and I think it is a very good article you may need to read. Finally, they conclude that cerebral salt wasting, or it's more appropriately to be called renal salt wasting, because both of them end with loss of sodium through kidney. Let's look here in cerebral salt wasting, there is increased kidney loss of sodium, whatever the etiology. And here there is a clear renal salt loss of sodium, whatever the cause. So finally, cerebral salt wasting is the same of renal salt wasting, and it is now called renal salt wasting, and both cause the same pathogenesis, as I will show you now. So there is no difference between renal salt wasting and cerebral salt wasting. The problem now, how to differentiate between SIADA and this salt wasting, because differentiation between them is very important, because the management of these both categories is totally different. In SIADA syndrome, we'll make fluid restriction, but in cerebral salt wasting or renal salt wasting, we'll give the patient fluids and even salt and even fludrocortisone. So two different aspects of management between two categories of the disease. Let's go rapidly again through the difference in the pathogenesis of the two categories, SIADA syndrome and cerebral salt wasting, which is the same as renal salt wasting. In SIADA syndrome, we know that this is an appropriate ADH release. ADH will cause severe water reabsorption, and here the urine will be concentrated and reduced in volume, and the water reabsorption will cause hyponatremia, and there is increased total body water. In cerebral salt wasting, there is a neurological event, or it may be without neurological event in what is called the renal salt wasting. So there is sodium loss from tubules. This will cause natriuresis, as we said, diuresis, and hypovolemia. And the hypovolemia will cause release of ADH and water reabsorption. So the hyponatremia in SIADA is due to increased water reabsorption. The hyponatremia in renal salt wasting is due to sodium loss followed by water reabsorption. So how to differentiate between those two entities? Both of them will have hyponatremic hyponatremia. Both of them will have high urine sodium concentration, here because the urine is concentrated, and here because of natriuresis. And both will have hypouricemia. In SIADA syndrome, the ADH will cause increased uric acid excretion. And in renal salt wasting, usually there is a tubular defect and also high ADH that will cause increased uric acid loss. The main differentiation between both is the urine volume and the volume status. Here, in cerebral salt wasting, there will be high urine volume because of natriuresis, and the patient will be hypovolemic. But in SIADA syndrome, because of the high level of ADH, there will be a decreased urine volume, and the patient will be eovolemic. That's why here, in SIADA syndrome, we will treat patients with fluid restriction, and here, in patients with cerebral salt wasting or renal salt wasting, there is hypovolemia, and we will treat patients with fluid therapy. So to conclude again, both SIADA syndrome and the renal salt wasting may be associated with intracranial disease, but to put in mind, the majority of patients in neurosurgical settings with hyponatremia due to subarachnoid hemorrhage, trauma, or whatever the cause, are mainly having SIADA syndrome, not cerebral salt wasting. This is very important. SIADA syndrome is common than cerebral salt wasting or salt wasting. But both have hyponatremia, concentrated urine, but the concentration is more in cases of SIADA syndrome. Both have high urinary sodium, both are non-edematous, both have hypouricemia and increased diffraction excretion rate. The main difference is the volume status, which is normal or high in SIADA and low in renal salt wasting. And here is an important clinical point. If the physician wrongly diagnosed SIADA as cerebral salt wasting, as we said that in SIADA, we'll make fluid restriction for the patient. If there is a fluid restriction in a patient with cerebral salt wasting, the patient will develop hemodynamic instability and frank volume depletion and hypotension. So if you diagnose the patient as SIADA and you started volume restriction and your patient started to be hemodynamically unstable and started to be shocked or to have low blood pressure, so please reconsider your diagnosis, as it may be cerebral salt wasting. Another point clinically to differentiate between SIADA and renal salt wasting is after correction of hyponatremia. After correction of hyponatremia, in SIADA, the serum sodium will be normal, this orange line. The serum urate will return to normal level, and the fractional excretion of urate will return to normal level. So in SIADA syndrome, after correction of hyponatremia, all of these parameters will return to normal. But in renal salt wasting, after correction of hyponatremia, the serum urate and the fractional excretion of urate will still abnormal. And this is second clinical point to differentiate between SIADA and renal salt wasting. Another point that helps in the differentiation between SIADA syndrome and renal salt wasting is a fractional excretion of phosphate. Not always found to be high in renal salt wasting, but may be high in this disease. It may be more than 20%, but not always. And this is even before start of management. So fractional excretion of phosphate should be determined before giving the patient saline or whatever the management that we will do. If it is high, more than 20, this suggests more the presence of renal wasting, salt wasting. But if it is normal, we can't exclude the presence of renal salt wasting. So to conclude the difference between SIADA syndrome, renal salt wasting, and cerebral salt wasting, volume before treatment SIADA is usually volemic, renal salt wasting hypovolemic, and signs of orthostatic hypotension will be present. Fractional excretion of phosphate before saline is normal in SIADA, may be more than 20% in renal salt wasting. With fluid restriction, is there any hemodynamic stability and frank volume depletion in SIADA? No, because that is the treatment. But yes, it will be found in renal salt wasting because fluid restriction is dangerous in this disease. We have to give the patient fluid. And finally, after correction of hyponatremia, you will find all these parameters corrected in SIADA syndrome regarding serum sodium, serum urate, or fractional excretion of urate. But in renal salt wasting, serum sodium when corrected, the fractional excretion of urate is still high and serum urate still low. So to revise what we said till now in the diagnosis of hyponatremia, step 1, repeat serum sodium. Step 2, exclude drugs. Step 3, exclude other causes of non-hypotonic hyponatremia, which are hyperlipidemia, hyperproteinemia, hyperglycemia, the use of hypertonic solutions. And if the diagnosis is true hyponatremia, which is hyponatremia with low osmolarity, hypotonic hyponatremia, is there any severe symptoms or acute symptoms? If yes, consider treatment, and we didn't talk about this till now. If no, go through step 5, and step 5 started by measuring urine osmolality. It is less than 100. Consider hyponatremia due to high water intake or low solid intake. If it is more than 100, you have to measure serum sodium concentration. It is less than 30, so there is low effective arterial blood volume, and we will differentiate the cause according to the extracellular fluid volume. If more than 30, if the patient is on diuretics or kidney disease, so this may be the cause. If no, you can differentiate according to the extracellular fluid volume. And you have to consider any other cause, whatever the osmolarity or the urinary sodium, because the patient may have mixed causes. So we discussed the presentation, diagnosis, and now we will go through the management. Starting by general rules in the management. We will use now, in some cases, to treat hyponatremia, we will use 0.9% sodium chloride saline, or hypertonic saline, 3% sodium chloride infusion. Whatever which one we will use, according to the indication, as I will tell now, there is a general rule for the maximum correctional limit, or in other words, when to stop the infusion, when to stop the hypertonic or the isotonic infusion in the treatment of hyponatremia, whatever the etiology. First, stop the infusion or your target as a maximum correction is to increase the sodium level about 10 millimole per liter than the baseline of the patient in the first 24 hours. Then your target in every other day after the first day to increase the serum sodium maximum by 8 millimole per liter. Also, your maximum correction limit, and you have to stop the infusion if the serum concentration reached 130 millimole per liter, or serum sodium concentration increases 10 millimole per liter in total, or you can stop infusion when symptoms improved. And by the way, if the symptoms still haven't improved, although the correction of the hyponatremia, it is unlikely that the symptoms are due to hyponatremia, and the alternative explanations should be sought. The second rule is that you have to know how much 1 liter of the fluid that you will give the patient will it change in serum sodium. For example, if I give the patient 1 liter of hypertonic saline, how much his serum sodium will be increased. You have to use this equation. A change in serum sodium actually equal to infused sodium, the amount of the sodium in the fluid that you are using, minus serum sodium, the actual level of the sodium of the patient, over total body water plus 1. And if the patient has a combined hypokalemia with hyponatremia, you have to include the amount of the sodium that the amount of the potassium that we infuse it in the equation too. First of all, how to calculate the total body water of the patient. Total body water is roughly equal to 60% of the body weight if the patient is male and his age is less than 70. And if the patient is woman and her age is more than 70, the body water is about 45% of the body weight, and the total body water is about 50% of the body weight if the patient is male with age more than or equal 70, or female with less than 70 years old. Regarding the infused sodium, take care and keep in mind that correction of hypokalemia will contribute to an increase in serum sodium concentration. If you will infuse potassium with sodium, you will need a less amount of sodium to correct the hyponatremia, because infusion of potassium can correct hyponatremia by many mechanisms. One of them that with the correction of hypokalemia, some of the potassium will go into the cells in exchange with sodium, and this will increase the serum sodium. Also, there is parallel intracellular uptake of chloride with potassium, and the chloride inflow into the cell has osmotic effect, will osmose water from the extracellular compartment to the intercellular compartment, which will decrease the extracellular free water, increasing sodium level, and so on. The third part in this equation, or the third arm in this equation, is the infused sodium. How to know the amount of sodium in the infused? It is well known that 0.9% sodium chloride contains about 154 milliequivalent sodium per liter, and the hypertonic saline contains about 513 milliequivalent per liter. So now you have all the numbers and you have to compensate in the equation. For example, and by the way, the target for correction of sodium is 125 millimole per liter. This is your target while correcting hyponatremia. For example, if we have a patient and we are aiming for a safe sodium of 125, the patient is 53 years old with 70 kilograms, he is a male, and his sodium is 115. And we want to correct his sodium to be 125. If you compensate in this equation, we will find finally that 1 liter of 300% hypertonic saline will increase the sodium of the patient by 9.25 millimole per liter. So now you have 1 liter of the solution and how much it will increase the sodium. And you have the general rules, the maximum correction limit per day. So you can distribute the volume of the infusion throughout the day. And by the way, this equation usually underestimate the correction. And there is another important point that you may, at the same time, treating the cause of the hyponatremia, as we will mention later. So the correction may be rapid with hypertonic saline. So it is important to frequently monitor the sodium level, because this equation is an estimation, just an estimation. The frequency of sodium monitoring differs according to the severity of the symptoms. In the European Renal Best Practice Guidelines, they differentiate it into every 4 hours, at hour 1, 6, 12. According to the severity of the symptoms, you can check these frequencies or use your own frequencies. But the main idea is to frequently monitor the serum sodium while monitoring to avoid rapid correction, overcorrection, and also to avoid slow correction, especially in severely symptomatic patients. So we finished the general rules of the management regarding what is the maximum correction rate and the use of the equation to estimate how 1 liter of the infusate will increase the serum sodium. Now, what is our stepwise approach? The approach for the management of hyponatremia depends on the symptoms. Is the patient symptomatic or not? If the patient is symptomatic, are the symptoms severe? Are the symptoms severe or moderately severe? And if the patient is not symptomatic, is the condition is acute or chronic? Starting by yes, the patient is symptomatic. And this is the point which was called step 4 that I bypassed while I'm talking at the diagnostic approach. Here is the point, is the patient has severe symptoms. If the patient has severe symptoms as vomiting, cardiovascular distress, seizures, and coma, here the first hour management of this patient, you have to infuse it 150 ml of hypertonic saline if the patient is average weight over 20 minutes. And in case of obviously deviant body composition, the very thin patient or the very obese patient, you can infuse it 2 ml per kilogram of the hypertonic saline over 20 minutes. At the end of 20 minutes, check serum sodium and start another 150 ml till the results of the serum sodium comes to you. You have, or you can repeat this step maximum twice, or maximum if the serum sodium increases by 5 millimole per liter, because there is an evidence that increasing in the serum sodium by 5 millimole per liter in patients with severe symptoms will improve the symptoms. If there is improvement of the symptoms, you have to stop the 3% infusion, but you can keep the intravenous line open by infusing smallest feasible volume of normal saline until cause-specific treatment is started. But if you repeated the patient, if you treated this approach twice, or if the patient reaches 5 millimole per liter increase in serum sodium and there is no improvement of symptoms, continuous infusion of the 3% saline, according to the general rules of raising serum sodium that we mentioned already in the first slide of the management, by the maximum of 10 millimole per liter in the first 24 hours, and thereafter by only 8 millimole per day. What if the symptoms are moderately severe, as nausea without vomiting, confusion, and headache? We'll start the same as severe symptoms, then, but without repeating. Start the 3% infusion over 20 minutes, but don't repeat it again with this volume over this time. And if there is improvement of symptoms, so we'll go as severe symptoms, and if no improvement, we'll continue targeting general rules of raising sodium. So the protocol for moderate severe symptoms is the same as severe symptoms, especially without the middle part of the approach. If no symptoms, we have to ask ourselves, is hyponatremia acute or chronic? If it is acute, that means that the patient developed hyponatremia in less than 48 hours. If the acute decrease in serum sodium concentration exceeds 10 millimole, we will give the patient only once infusion of 150 milli of hypertonic saline over 20 minutes. If the patient developed chronic hyponatremia means that the patient developed hyponatremia over more than 48 hours. If hyponatremia cannot be classified, we don't know the patient is acute or chronic hyponatremia because we don't have a baseline sodium level. So we consider hyponatremia as chronic unless there's a clinical evidence of acute hyponatremia or severe symptoms. If the patient has chronic hyponatremia, it depends on the circulating volume. The effective circulating volume, is it reduced or not? If it is reduced, as it was in our approach regarding diarrhea, vomiting, third space loss, vomiting, adrenal insufficiency, renal salt wasting, cerebral salt wasting, we have to infusate the patient with saline or paraffin crystalloid at 0.5 to 1 ml per kilogram per hour, but don't forget targeting general rules of raising sodium regarding maximum correction rate. But if the patient is shocked, you have to give a saline to or volume replacement to compensate this shock, and this is more important than the rapid rising of sodium if we give a larger number of saline, because saving the patient life is more important than the hazardous effect of rapid rising of the sodium. And there is another protocol that may help us to give a large volume of saline without rapidly increasing the sodium level that I will mention at the end of this lecture. What if the circulating volume is not reduced? Is the patient edematous or not? If the patient is edematous, as in case of heart failure, liver cirrhosis nephrotic syndrome, the main is fluid restriction. And these guidelines goes against the vasopressin receptor antagonist use because of its side effects and its cost, and it also need experts to its use. And also, although there are some trials used vasopressin receptor antagonist, either intravenous or oral, but actually they improve the sodium level, but haven't shown to improve heart failure outcomes. The guidelines goes against demiclocycline also, or lithium, for the treatment of any degree of hyponatremia because of their side effects. And sure, consider furosemide in these patients. What if the patient's extracellular fluid volume not expanded, as in SIADA syndrome? In SIADA syndrome, actually, our experience as a nephrologist is less than endocrinologist in treatment of SIADA syndrome. But in general, the main idea of the management is fluid restriction, but it is not enough because this patient excretes excess sodium in urine. So we have to give urea tablets or combination of low-dose loop diuretics and oral sodium chloride beside the fluid restriction, because fluid restriction alone will not be enough. Again, this guideline goes against lithium or demiclocycline and against vasopressin antagonists, although there are some evidence that some centers tried the demiclocycline, but the got side effects limit longer use, and also some use tolvaptan, although we all know the cost of the tolvaptan. But the most important clinical point, if your center has experience to use tolvaptan in SIADA syndrome, is not to fluid restrict the patient. Don't fluid restrict the patient. Allow patient access to free water and to monitor sodium regularly, because you will give the patient a drug that block the ADH effect, so there will be a loss of high free water from the urine. So this is the management. We talk about the approach. It depends on these symptoms or not. If yes, if severe, we have a stepwise approach for the use of saline, hypertonic saline. If moderately severe, we also have a stepwise approach for the use of hypertonic saline, but with a less step than severe symptoms. If acute, we will also use hypertonic saline if the acute decrease in serum sodium is more than 10 millimole per liter, but only once infusion over 20 minutes. If chronic, It depends on the circulating volume. If it is reduced, we will use saline. If it is not reduced with edema, we will have fluid restriction with diuretics. If it is not expanded, we'll have fluid restriction with urea or with sodium chloride tablets. The third part in the management is overcorrection. What happened if there is overcorrection? Or what happened if there is a rapid correction? All what we are afraid from is osmotic demyelination syndrome. It is a rare but a dramatic complication. What happened? We said that the brain adaptation for the changes in the serum osmolarity is slow. As we mentioned in the beginning of the lecture, that the patient adaptation for hyponatremia occurs over 48 hours. So if there is rapid correction of sodium, this will lead rapid increase in plasma osmolality, which will cause rapid shift of water from intracellular space from the brain to the extracellular space, because brain cannot reuptake its osmoles that the brain already get rid of them out to adapt hyponatremia. And this will cause brain shrinkage and demyelination. Who are the patients who are at risk for osmotic demyelination syndrome? These patients, correction of sodium should be given at a slower rate. Patient with serum sodium less than 120, sure patient of rapid correction more than 8, patient with hypokalemia, and we said that the care because treatment of hypokalemia will increase serum sodium, alcohol abuse, malnutrition, and patients with liver disease. And you have to put in your consideration also that there are some situations the specific treatment of hyponatremia are so effective that they may be enough to autocorrect their hyponatremia faster than 8 millimole per liter per day. As in case of sarcogenic polydipsia, T and TOS syndrome, case of volume depletion, thiazide-induced hyponatremia, and adrenal insufficiency. Maybe treatment of the cause is enough, especially if the patient has no severe symptoms or moderate severe symptoms. But actually, there are case reports, although you may be going through the approach of treatment of hyponatremia and with slow correction of hyponatremia, the patient may catch osmotic demyelination syndrome. There are cases of osmotic demyelination syndrome reported despite guideline-based correction speeds, but these are case reports. How to diagnose osmotic demyelination syndrome? MRI is sensitive, but lesion don't become apparent for up to 4 weeks, so negative study may not rule out the disease. So what if rapid correction happened? What I have to do to decrease the serum sodium again? If sodium concentration increase more than 10 millimole per liter during first 24 hours, or more than 8 millimole in any 24 hour thereafter, for sure discontinue the ongoing active treatment to stop the hypertonic saline or whatever what are using. And you can give the patient dextrose, and also you can consider expert opinion and start to use Desmopressin. But this needs expert opinion to retain some water and decrease the sodium level. This approach that I mentioned before, if you want to avoid rapid correction of hyponatremia from the start, what is called Desmopressin clamp protocol. This is an approach that wants or needs a high expert level. At first, don't use this approach in patients with volume overload or symptomatic hyponatremia, because it will raise, regarding symptomatic hyponatremia, we can't use this because it will raise the sodium level very slow. And regarding overload, volume overload, don't use it because you will give a volume of saline with Desmopressin. In this approach, I will not go through its details, but in this approach, from the outset of the treatment, from the beginning start of the treatment, start Desmopressin with the sodium chloride infusion at the same time with fluid restriction. This will ensure that sodium goes slowly, but this needs a high expert opinion, a specialized center with high rate of management of hyponatremic cases. Finally, the last point of the management is dialysis of hyponatremic patient. What if you have a hyponatremic patient that needs hemodialysis? Theoretically, dialysis will correct the serum sodium of the patient rapidly. You will dialyze the patient for 2 hours or for 4 hours. So theoretically, the patient will take sodium from the dialysate, which will rapidly correct the serum sodium of the patient and may cause osmotic demyelination syndrome. So what are the precautions that you can do to avoid this? First, you have to make maximum difference between the dialysate sodium concentration in your machine and the plasma sodium level of the patient by 15 to 20 milliequivalent. So adjust the sodium on your machine to be only higher than the patient's sodium by about 15 to 20 milliequivalent. This will ensure that the rise of the serum sodium of the patient will not rapid. Second opinion, if the patient, especially if the patient is severely hyponatremic and your machine lower limit will be more than 15 to 20 milliequivalent than the patient's serum level, you can use dextrose 5%. As we mentioned, we can use dextrose 5% in overcorrection. Also, we can use it in hemodialysis machine. Every 1 liter of dextrose 5% decrease serum concentration by 3.5 milliequivalent per liter. So you can infuse it 5% dextrose during the hemodialysis session. And third, and the safest, is to use continuous renal replacement therapy. This safely correct hyponatremia and results in a more gradual correction over a longer time span. But there is an important point in our patients that uremia may provide some protection against osmotic demyelination. We said that if there is rapid correction of sodium, this will rapidly increase in plasma osmolarity, and this will may osmose water from the brain cells and cause brain to be shrunken. But actually, if the patient is uremic, he will have a high intracellular urea level with high intracellular osmolarity, and this may compensate for the rapid correction of sodium. That's why the incidence of osmotic demyelination syndrome may be less in hemodialysis patients with high urea level. Finally, my home messages. The presence of symptoms and severity of hyponatremia depends on both the magnitude of the hyponatremia and the rate at which the hyponatremia developed. Normal maximum compensation for a decrease in plasma osmolarity by the brain typically requires up to 48 hours. So avoid rapid correction of hyponatremia. Hypertonic saline infusion is mandatory in severe symptoms, moderate symptoms, and acute presentation, especially if acutely the sodium decreases more than 10 millimole per liter. Uremia may provide some protection against osmotic demyelination, and thank you.